meeting. Oh yes, thanks, Jondi. Thanks for joining us. This is our February meeting. You are currently in the Oregon Cost Growth Target Technical Advisory Group meeting. This is, we don't have an official membership roster. It's whoever can come and would like to participate can do so. It is mainly staff from payers who are the program's data reporters, staff from provider organizations. So data collected from insurers are going to be relevant to and reported on both those two types of entities, payers and provider organizations, but also open to other interested groups. Sometimes we get folks from other states with cost growth target programs, other advocacy groups interested in understanding how the data works, some of the more technical aspects. I'm going to zoom out a little bit in this intro part because I know we have a couple new people joining us today. And if you are not on this meeting invite, it is a year-long series, a monthly series of meetings we hold. All of that information is on our Cost Growth Target webpage, the Technical Advisory Group webpage. So you could always click on the meeting link there. But if you would like a calendar invite, please let us know, email us. You could, jot your email in the chat and we can get it at the end of this meeting too. So just a reminder, this is a virtual meeting. So all we see, when folks talk are their names. So if you haven't already, please edit your name and include the organization you're affiliated with. It helps with questions and figuring out who's asking what in the chat. I think that's all I wanted to say up at the top. Sarah, did you want to add anything to for our slightly larger than usual group today?
Nope, just Trang, did you introduce yourself?
Oh my goodness, I did not, and I'm usually so good at that. Hi everybody, my name's Trang Weidemeyer. I use she, her, they pronouns. I'm a policy analyst with OHA, working for Sarah and the Cost Growth Target program. I'm the person who has been emailing a bunch of you about the data for this year. And we'll talk about how we want to present it and visualize it for the bulk of this meeting. All right, let's go to the next slide. Okay, so this is the agenda we have today. We're doing, if you're a frequent attendee, we're switching it up a little bit because we know the main attraction for today is discussing how we want to visualize and publish entity level data in our upcoming spring public report. So that's item number 2. Everything else we just kind of loaded on the back end. They're just quicker topics to touch on. We will be talking about very briefly just the list of provider organizations for the 2022 data cycle are out. We've been in contact with all of them, and the list is now posted on our website. And we've already met with a fair number of them. I forget the exact number, but pretty much all the big ones. And then whoever else would want a meeting as well, but everybody's gotten their data. Topic number 4 is just a heads up, now looking forward to September 2023. Just a reminder that we are going to start talking about that at the next TAG meeting. And to remind folks, if there's any comments, feedbacks, or maybe even requested changes to data submission guidance material to let us know about that. And then we'll finish up with some quick program updates and end the meeting. Next slide. Okay, so let's get into it. Let's talk about what this data looks like. Just to remind folks, the program's ramp up was designed to ease into accountability, the first level, which is transparency and reporting. So data last year that was collected in, data collected in 2021, our initial data cycle, only going to be reported at the state and market level. Data collected in 2022, just last fall, this data is going to be reported at the entity level, not in the super granular way which you all received in your data outputs. It's just the cost growth trend, so the percent trend. And we'll get into that, getting ahead of myself. So what we want to talk about today with all of you are some options for displaying what that data looks like. We are anticipating a lot of good productive feedback and commentary on this. So we really want to focus our energy and time on this topic. If folks have other thoughts on other topics, data submission methodology, bills, ledge stuff, you could always reach us via our email. But just a reminder, we really want to give space for this topic today. Are there any questions before we get started? Nobody's in the waiting room? Okay, let's go. Gerandi, next slide. All right, so the data for this report that we collected last fall, this will be presented in a future report, tentatively planned for this spring. This is healthcare spending between 2 years, 2020 and 2021. In all of our data meetings and communications, we've been relaying to folks, reminding folks, you know, these cost trends do cover COVID pandemic years. They are going to look a little weird, to put it lightly, but the dollars are real, the trends are real. So we do want to talk about it. It does deserve talking about it. So we will give context around that in the report and any future public hearings, but we're not going to focus on that for today. Today, we want to focus on the data display and the technical aspects of DataViz. So the data source for this are the 2022 data submission files. We collected them September of last year, validated them through the fall, met with provider organizations early this year. We're still continuing to meet with a couple this month if they opted for meetings. I think that's all I wanted to say. This report will be reporting at all 4 levels, the state, the market level, and the payer and provider organization level.
Trang, let me jump in here. I know we've had a couple of questions about when this report will actually be released and the timing of the report and the planned public hearing. And I think we do not have a firm date pinned down. I think we've been signaling spring for a long time. And I think the closest we can get at this point is likely this report would be scheduled for release the first week of May. And then public hearing would be mid-May. So we've had some concerns and questions about how much space there is between the release of the report and the public hearing, and sort of time to digest the information. And we hear that. And so we're thinking about staggering that. So I think at this point, the best information we have is report first week of May, public hearing mid-May, and we'll keep you posted on the timing.
Thanks. Any other questions? All right, let's go to the next slide. Okay, though we already touched on this, these are today's goals. And we're hoping for a lot of feedback to help us shape what this report looks like. Next slide. All right. So if you've been following the program, or if you've been, exploring our website, you'll see there's already a couple baseline reports that the program has put out. You'll see a lot of longitudinal trend graphs that look like these. Year to year per person cost growth. Here are just some examples, one from our cost impacts report on the left, and then the other from a health spending report using APAC data. We'll keep visually, using the same conventions, color styles, reporting statewide, commercial, Medicaid, and Medicare. So chopping up those markets, it'll look very similar to this. Next slide. Just a reminder, when we are reporting at the payer and provider organization level, we are only reporting the cost trend, so that left-hand column. This is the year-to-year cost trend. The way the program is designed, it is looking at 1 year to the subsequent year. This is a percent trend in per person growth. We are also reporting the 95% confidence intervals. If some of you will remember, we were the first state to institute that because we wanted more statistical certainty, whether above or below was statistically relevant. So you will see, and you'll see in some of the examples going forward, sometimes those confidence intervals can be very small, or they can be very wide, depending on just the variation in your per person trend that year. And then we'll also report whether the target was met or not. Just a reminder, there is no accountability this year. There's no consequence depending on whether the target was met or not, but we want people to get used to how we're reporting this, how we're using those confidence intervals, and what it means if the target was met or not. It's not always bad. It's not a value statement whether you met the target or not, especially initially. And we've talked about this a fair bit in our data meetings with individual groups of people. But yes, those will be reported. Oh, and another note, these trends are going to be reported by market. So you may be a provider organization with only a Medicaid market, even if you do have attributed patients, maybe in the commercial market. In our data, if you don't meet the size cutoff, then we're not, not going to look at that. What is not going to be published are the more granular bits of data. So for all payers and all provider organizations, we gave you all your data summaries and basically showed you, this is as granular as the cost growth target can receive it from data reporters. which are the payers. For data providers, we have to merge and assemble all of your data from each payer file we receive. So the file provider organizations get is from the statewide merged file. Payers, the data summary you get, it's, you know, kind of a aggregation, recalculation of the file you literally sent us. In those data outputs, we show you granular calculations, things like per member per month for markets, for different claims and non-claims, service categories, and we'll show you the percent trend for those categories. So we give you a couple different breakdowns below the level of market. But those are not reported in the public report. Those are for your organization, your staff only. And I think that's all we wanted to say about that.
Trang, let me take it up a little bit higher level than that. I think just to restate, we do have a lot of information and we've been trying to be really transparent. The payers, you've given us this data, so you know what's in it. We're trying to have conversations with you about how we're looking at it, what we're looking at, how we're pulling it out of what you submit and how we translate that. And then at the provider level, here's what your data looks like in great detail. And I think in the provider data meetings, we've talked a lot about what we can understand from those data outputs, and they're really detailed. But I really just want to emphasize that we are not planning on publishing that level of detail. And there are a couple of reasons for that, and we can talk about them. But I think one thing that comes to mind for me is there are some big differences in PMPMs. There are some big differences in how the dollars are, where the dollars are. So some organizations provide more behavioral health than others, and they might see more in their behavioral health trends than another organization. Some in the larger health systems might see more in the hospital side, because that's part of the whole system and the attributed patients that they're seeing dollars for. So we are not getting into any of that level of detail in this public report. It's really just top line only. All of that information is super important for context. And I think one of the reasons we want to have this conversation with you today is to understand from you and your perspectives what context is helpful to explain those top line cost trends without releasing all of the details. So again, just emphasizing, we're really hoping to hear from you on feedback in terms of what's helpful and what's not helpful. There's a lot of context in that data that we're not publishing, and that data can be overwhelming. So how do we make that context really clear to explain what's happening on the ground for you all? Okay, sorry, try and keep going.
No, that's great. All right, let's go to the next slide. Okay, so we are not alone in Oregon in this line of work. Before we start to get into, well, actually, this is us getting into the questions. We wanted to show you all what other states are doing, how they're choosing to report. And as we go through these slides, we'll have some prompts for you. Take a look at how this state is reporting their data. What do you like about it? What do you not like about it? I think another thing to keep in mind is that Oregon, the way we're collecting data and our size threshold, we have a lot more payer entities and provider entities than some of the other states. Some of the other states, we're talking, you know, like 10, like a graph with 10 points on it. So just keep that in mind as we walk through these. So let's start off with, what are we starting off with? Rhode Island. Next slide. Okay, there's the link to the PDF report if you would like to see. This is just a screen grab from Rhode Island's report for commercial payers. You can see here they have just 4 on this page. The x-axis is nothing but the name of the payer. The y is just the cost trend from year to year. I believe this is 2020 to 2021. Sarah, this is their most recent, I think. It might be 19 to 20. I forget. It's in that link over there. But along the X, you could see there's, you know, the 0 line. That means growth is flat. It's not positive or negative. And then you can see Rhode Island's target, which is lower than ours, 3.2%. They've also adopted confidence intervals, so you could see the bands for that. What's not shown on this slide, but is shown on their report, is they not only have this graph of the growth trends, but they also have a table listing those for payers with either met the target, did not meet the target. Are there?
Let's go to the next. Sorry, let's go to the next slide because it's really similar. I think let's talk about the state collectively.
Yeah. So here's a very similar looking graph just with provider organizations. This time we're looking at the market of Medicaid.
And next, I think.
Okay. So after seeing that, oh, and here's an example of the performance table, either met the target, did not meet the target. Just looking at one example so far, Rhode Island, are there things people liked about this presentation? Do you have any concerns about Oregon using an approach like this? Is there anything confusing about it for people?
Hey Trang, this is Sam. Hey everyone, I'm OHA. We've probably met on our calls. I really like that everybody's met the target. First of all, that's a great goal. It's very simple. There's not much here. We're saying that you met the target. We've got the confidence intervals, which is nice, but Rhode Island is just so small. If we were to do this with our data, the names themselves would be so tiny that we wouldn't be able to see anything, right? It doesn't seem like maybe some of the organizations would like to be hiding in very small print, but we want to make it as obvious as possible where everybody falls so that you don't have to get out a magnifying glass, right? It almost seems like a table like below would make more sense rather than a graph, but everybody likes graphs, so I'm not sure how we would tackle that.
One more thing I want to add is that, of course, all of these reports from other states that we're going to talk about do have narrative that talk about the context and what's going on, and our report will also have that. We're only focusing on the data visualization today, so I don't want to insult any of the other states and imply that they have not provided context and narrative around all of this data. They have, and we will also do that. So that I know that's a big part of the reporting and concerns that a number of you have expressed to our team. But again, as Trang said, we're really just focusing on visualization options and how to present this information as clearly as possible. Any feedback from people? Larry.
Yeah, thanks. Larry from YCCO. I guess, Sam, to your point, have you done any mock-ups of what this would look like for Oregon de-identified for these solutions?
I'll take that one. Yes, and we are not sharing them today. I think let me put out there that if this is something that, after we go through a bunch of the options and we land on, here are some preliminary preferences and you would all like to see a de-identified mock-up in the March meeting, I think that's something we could commit to.
I mean, even if it's just, false data, everybody's on the same, just made up data to see what it would look like with that many entities on the same graph, I think would at least give us a better sense to react. Sam, I think you're probably on the right track. It might be too busy.
Yeah, I mean, I'm being a little bit of an antagonist here, just because I think we do need to have some sort of visualization to make it more interesting. While a table full of names and did not meet target or did meet target is useful, and it's an easy, just checkbox. There is more information in there that we can get across, and we kind of want to think about in this conversation what data is important that we want to get across. Are the confidence intervals useful there? Are people who are less familiar, maybe on this call even, comfortable with what those lines mean on that graph? Is that useful information, or is there something else? Is there some other information that we can put on a graph that would be more helpful when you're looking at this at a glance? And that is an actual open question, because I'm not sure that confidence intervals are the right way to go. But
And
Yeah.
let me take us back a step, because I think we're probably throwing too many questions out at everybody. So let me propose, let's go through the other two states and show a few more examples. And then we have some examples to show you for options. So let us put some more options out, and then we can come back to your reactions. I think we're probably pushing a little too hard here. So Trang, why don't you go on to Massachusetts?
Yeah, that sounds good. Okay, let's look at Massachusetts. So Massachusetts looks a little different. This is looking at payers, looking at their commercial market. So as you can see, they have more payers on their graph, and they've arranged them by member month size. Right, so the cost growth trend is still on the y-axis. I know myself, I found it a little tricky to interpret. You have member month size on the X, and then you also have different size circles, which are also member month, just a different way to visualize it. And again, you have there that dotted line in light orange for their statewide target, which their statewide target is 3.1%. One thing to note, there are no confidence intervals here. So while you can see 3 payers are above the target,
And that's because Massachusetts does not have, Massachusetts has not adopted the confidence interval approach in their reporting. So it's not that they have it and chose not to display it. They are not using it in their program. What they're showing here are the respective size of each payer, and then the different colors, if you can tell the difference, are different. The 3 largest compared to the rest of them. So really, they have 3 different ways that they're showing who the bigger entities are.
Yeah. So yes, aside from the 3 largest on the leftmost side of the figure, you also have gray circles and light blue circles, and those are denoting domestic and foreign payers, national payers like Cigna, Aetna, and then Massachusetts payers. Yes.
Next.
Yep. So this one's a little bit different too. So this is their physician grouping, their managing physician group. So this would be kind of like our provider organization. You can see they have, let's see, what is that? 8, 9 or so running along the bottom. You've got cost growth trend along the Y, same as the other figure, but they broke it out by the 3 largest payers. This is the commercial market. They broke it out by the 3 largest commercial payers for each provider entity, for each physician group entity.
So this is not something that we're currently talking about for Oregon. We do want to ask you what you think about this, but just wanted to reflect, this is another level of granularity. I know that when we've talked to a number of the payers and providers, you've had questions and you've said, okay, what does this look like if I only look at my largest payer? And in some cases, we're able to pull that data and give you sort of that stratification. That's not something we've ever talked about doing for public reporting. So this is a step below that, and I'm really curious to hear what people's reactions to this are. This might be something that's, you know, too advanced for us in our first public report, and we come back to it later, but just wanted to reflect that this is an extra level of granularity beyond just reporting at the payer or provider entity level. Okay. I want to flag something, a couple things from the chat. So slides are available online. The link is in the chat. We can send them out after the meeting as well for a reminder. And we will be happy to accept your feedback over email. So if you think you need a little bit more time to digest this information, or if you want to talk to your team internally before getting back to us, please feel free to send us comments over email. I think we're asking for your feedback by March 15th. So we'll come back to that at the end for next steps, but just clarifying that you do not need to speak up today. We'd love to hear any initial reactions and comments, but also feedback in writing over the next 2 weeks is great.
Trang, this is Tracy from Aetna. If you were to report the provider level, how many providers would you plan to report? I know that we report on all of them as long as they have 13 member months or more. So.
Yes, I was just going to say, we'll get to that in a future slide. We do know how many providers per market and payers.
Let's skip ahead to that actually. Gerondi, can you skip to the, I don't know, it's like maybe 8 slides. Keep going. Keep going. Okay, one more. This one. Back.
Yes. So this is the breakdown of how many entities you could expect to see for each market. So for payers meeting the size threshold, the payer commercial market figure, that would be a figure with 8 entities. Medicaid is the busiest one with 16. And Medicare has 10. In provider organizations, we have a lot more entities, 51 total. And I think, yes, Medicaid is going to be the busiest figure for that also. So 46 provider organizations had attributed member months in the Medicaid market that were big enough to be scooped up in the cost growth target net.
And I think because we plan to report at the market level, we are not planning on any visualizations that would have all 51 organizations in the same chart. At the highest level, we would only have market. So there would be a commercial graph, a Medicaid graph, and a Medicare graph, I think is where we're at currently.
Mm-hmm.
Tracy, does that help?
Does, thank you.
And we have a hand up, looks like. Go ahead.
I just wanted to suggest that something that might be a really easy thing to do when you have that many data points that you want to graph might just be a scatter plot.
Yeah, we can add that to our mock-up list. Great comment. Trang, we're jumping around all over the place. Do you want to go back really quickly to Delaware?
Yeah. Gerondi, that's slide 15. Yes. Yeah, so here's kind of a slightly different look. Again, you know, we're looking at Delaware payers. They only have 5 on this graph, but you'll see a couple examples we mocked up that, you know, kind of stack them like this. And the great thing about it is you can easily read those names if they're stacked vertically with each other. And so they've put their cost growth trend value on the x-axis, 0%, the flat growth line, and then their target, which is 3.5. So you can, pretty straightforward visualization. You can see those bars going left or right, positive or negative, which ones go above the target line. So that's Delaware.
So I think I'm gonna keep us moving. Maybe let's jump to slide 20 and go right to our starting proposal for the Oregon visualization. So let me give a high level. So the table on the right, or the table on the right, summarizes some of the design choices, and there's some previous slides that just go through these design choices for each of the other states. So we do intend to report by market, as we said. So there'd be one graph for Medicaid, one for Medicare, one for commercial. There's a placeholder about, do we want to talk about that extra level of granularity for payer and provider like Massachusetts did? We definitely want to show confidence intervals. We're not sure about showing relative size, and we're not sure what order to organize entities in, and we want to ask you about those specifically in the next couple of questions. But on the left, you can see our proposed visualization, which is stacked like the Delaware option, shows the confidence intervals and has the organizations listed along that axis. With the benchmark line, everything is shown relative to the benchmark line, and we would also have a met and not met table, as well as the narrative that we've talked about. Any immediate reactions to this proposal?
Sarah, it's Tracy again. What are the blue dot within the gray? What is that the confidence level?
The blue dot is the actual growth. It's the percent growth. And then the gray bars are the confidence intervals around that growth.
Okay.
So if you remember, and this might be more of a provider conversation than we've had than the payer conversation, but in this example, organization A, their cost growth and the full confidence interval is to the right. They are above the target definitively. Organization C is below the target definitively. Organization B can't tell. Confidence interval overlaps. We're not sure. We would not say that organization B has met or not met. They're undetermined. Thoughts about this?
Hey, Sarah, this is Daniel Porter from Legacy. This is pretty, I think it's pretty elegant, really. I think it combines some of the best of the other states and takes out some of the noise too. Even with pair names along the y-axis there, I think coming up with abbreviated versions of the pair names, sort of like Massachusetts did, may be helpful for all the reporting, just get people used to sort of small names rather than the full, legal names that entities use. But the sort of the design choices you made here, I think this is pretty good and easy to read quickly, and it takes out some of the noise. So.
Thanks, Daniel. I'm having a hard time not hearing you say that as like a simple but elegant solution. Other comments about this?
Maybe if we go to the next slide and people can see some order options. Yeah, so in the previous slide, we just saw those organizations. They could be payers or providers. They were just listed alphabetically, which other states have done, and Oregon, we can do it too. But there's a couple other options for ordering that might give people more information. Maybe it makes more sense to view organizations not in alphabetical order. So two of the big ones are by size. These would be the member months that have been attributed to them. So that's the option in the middle. Another option is just ordering by growth trend. So you can easily see either from lowest to highest or highest to lowest. So those are those options right there. Are there
And
any thoughts? Yeah.
There might be another option that we haven't thought of, so we're also open to additional suggestions here, but any immediate reactions and preferences among these three? Eric, I see your hand up.
I was going to ask a question, but I think alphabetical just makes the most sense for everybody, because I think anything else, you're pointing out stuff that doesn't necessarily need to be pointed out. But that is, so you let me know when you're ready for my question, but that was my opinion. So.
Yeah, no, go ahead with your question. Thanks for the opinion.
Yeah, so the question I have is that you have, at least at the provider level, you seem to have pretty large variations from year to year in growth trend. And so how do we, on these, simply on the graph, be able to show that, it was a negative 24 last year and a positive 50 this year? Like, how does that, when you roll it, do you put the two together so that the reader can see like because at least the provider level, that's the case because of the size of the sample that we're talking about.
Yeah, so I think, Eric, that you're hitting on a couple of points, and I think some of what you're talking about is potentially things we want to get into in subsequent reporting. This is our first report, so we don't necessarily have, multiple years of identified trend that we're planning on showing. We've got this initial period for public reporting. I think in future years now, then we'll talk about how do we aggregate this and show more over time, and that might be different visualizations. But I think thinking about this as just an initial point in time snapshot, how did that change? And then Trang, I want to clarify, this is all fake data in these mock-ups. So please don't interpret this as the actual spread that we're seeing in Oregon right now. This is just a mock-up for demonstration purposes only and does not reflect the actual spread. I think in any given year, in particular, 19 to 20, we saw that really steep drop, and 20 to 21, we see a really steep increase as utilization came back, and that's all pandemic. So I think we can anticipate quite a bit more clustering than you might see in these mock-ups. And there are ways to handle that, so maybe we spread out the axis a little bit more, but that's really, again, this is fake data. Please don't try to figure out which organization you are on here. I'm seeing a lot of comments in the chat for alphabetical. And I think Ruth, you said not changing the order so there isn't always one payer or provider at the top or the bottom. That might be in conflict with alphabetical, although we do know organizations change their name, so there could be some shifting around, not suggesting anyone, rebrands to avoid reporting order. Any concerns with the conflict between one organization always being at the top or bottom if we go alphabetical?
No.
No.
No, okay. I
No.
agree, it's easier to identify, and especially over time, you get used to sort of seeing where you are. Like, do you always look at the middle of the chart? Do you always look at the top of the chart where it might be harder to find an organization using one of these other orders? Okay, I'm seeing a lot for alphabetical. I think if no objections, let's move forward with alphabetical for now. Oh, okay, swings for provider organizations. Yeah, agreed. This is all explanatory, Deborah, totally. There'll be a lot of narrative and how we package these graphs. We're just talking about the graphs themselves today, not about the rest of the context of the report.
Sarah, I am happy to see everybody chiming in and sort of coalescing around alphabetical. I just wanted to push back just a little bit because, I mean, when I look at these, obviously the growth trend on the right side gives me some real satisfaction of seeing, the being able to group who is over or under, who hasn't met and who has met. I think for us, if you're a payer and you're specifically looking for yourself in this list, your organization, it's really alphabetical absolutely makes the most sense. If you're not with a specific organization, if you were coming from the public or somebody who wasn't with one specific organization, and you just wanted to get a feel for where like groups of those that are above or those that are below the cost growth target, grouping it differently or grouping it in a more meaningful manner instead of just with Aetna always being at the top because they're going to be alphabetically at the top every time. I think there is some usefulness from a non-payer or provider specific view. It just matters who you kind of are, what perspective you're taking when you're looking at these tables.
Sam, I'd love to push back just a little bit that I think as a provider, we don't have confidence in the year-to-year data. We just don't. And so we're gonna, a provider could be at the top of the list one year and at the bottom of the list the next year, and it doesn't give the reader the chance to understand that. They're just look at it and go, oh, yeah, these guys are either good or bad. From a provider standpoint, because we don't feel that we have direct control over the cost trends in this, we're just reacting to it. Yeah, I don't think it's helpful from the provider perspective to have those things be any other thing other than alphabetical. So just one opinion, and I apologize for throwing a bomb.
No, Eric, thank you for that point. This is exactly the kind of conversation we want to have today. So please keep the feedback coming. I put this in the chat also, but I want to counter offer. What if we actually did 2 graphs for each graph? What if we presented the data both ways, both alphabetical and by growth trend, so that you could see it from both perspectives? Would that be helpful? Would that just be confusing? Would that muddy the waters too much? My team is shaking their head no. I'm seeing mixed emoji reactions from people. Ada, you're asking who the audience is. I think this is a public-facing report. I will say this is a very wonky public-facing report, so I don't know that the audience here is like your next door neighbor person on the street, general public, although it certainly would be available to the general public. I think the audience here is health system folks, policymakers, legislators, folks who are interested in cost containment and how we're doing. So it's a fairly informed audience, but definitely a general audience. Daniel, I cut you off, I think.
Oh, I was just going to say that sort of appeals to me. I agree that the growth trend is good for telling a story quickly. I'm trying to think if one is better or worse if you have 46 entities listed on the page, right? Like trying to, maybe alphabetical is the only way to go there, but it still doesn't tell a story. It's just, it looks noisy. It's less easy to process. Again, I agree with sort of all the comments about if you're looking for your entity, alphabetical is definitely the way to go and getting those reps graph after graph. But I appreciate the perspective that maybe both views are useful, considering we have different audiences looking at this.
And I want to say that there might be different pieces of the report. Like if I think about this as someone who's going to be writing some of this report, putting the growth trend order in the executive summary might be what's helpful. But then the bulk of the report with all the data is the alphabetical sort of standard reporting. Would that make sense to people?
Yeah.
I still don't think, though, it feels like then you're ordering organizations based on that outcome. It concerns me that there's still no context to that at the executive level.
Okay. I think I'm hearing a strong preference for alphabetical and a lot of concerns about context. Is that a fair summary of where we all are right now? Okay, let's go to our second question. Next slide, please, Johnny. Okay. So, Trang, you want to frame this one up?
Yes, and we don't have to spend too much time on this, but, oh no, yes, actually, this has changed. So this is talking about relative size. So there are still ways we can, you know, see a little bit more information on the landscape of entities, even if we don't order it by relative size. Here are two options. Yeah, the one on the left is we're ordering in growth trend order. So we're kind of copying Massachusetts with these bubble sizes here, but we're highlighting the 3 largest. It doesn't have to be 3, it could be 5 or so. But we are highlighting the bubbles that are the largest entities along that spectrum. On the right is what it would look like if we did it using alphabetical name order. So you can see these organizations, you know, they're all scattered along the spectrum. It is an alphabetical order, so you don't have that growth trend amongst entities. But yeah, that's what that would look like. So we could play around with color in these graphs. I see we have a hand up from Jay Nelson.
Yes, hi.
Sorry.
I don't know if this idea would work out or if it's possible, but an alternate way looking at the right side graph might be that organization C, which is one of the larger entities, might actually have might have their bar be at a greater vertical distance, so that you're widening the bar to reflect the size of the organization, because then that could still lay it out member by member in an alphabetical order, but how much space they take up on a page would actually represent how many member months are being pushed through that organization and their rate of growth.
Like that. I want to play with that and see how complicated it actually gets on the graph, but I like it as an option to test out. Thank you.
Yeah, I don't think I've seen anything like that. Yeah, that's a great suggestion. Greg, Daniel?
Yeah, the only thing I would say on that is if you're in other places showing that bar distance to represent the confidence interval, you're now going to create confusion, because now you've got the same type of visualization being used to communicate 2 different things.
Oh, and sorry, let me just make sure we're all talking about the same thing. I think the suggestion actually said width, and I don't think that's what meant. I think it's making the bars chunkier. So the bars would be taller for larger organizations. The width is still the confidence interval. So it would be displaying both the confidence interval and the thicker the bars are, the larger the organization is.
That clarifies. Thank you.
Okay. I agree. Now you're conveying 2 things in one visualization, and that might be confusing, but not that we're switching what the visualization means.
Well, one more question I would have, and this just in general, what exactly are you attempting to communicate by showing the size of it? Because there's the question is whether we look at those ones where you have the graphs where you slide things alphabetically versus sliding down. I would sit there and say that when you start looking at this, what is the goal of what you're trying to do? Are you trying to go out there and say, we want people to understand who's big and who's small, you know, for relative of importance? Because that may not be an important matter when you're talking about trying to get a feeling for entities and, you know, whether or not they're meeting the cost growth target.
Yeah, and let's go back one slide for a second, Gerondy. I think for me, the question about how do we order them, we have to show all of the entities somehow, right? We have to show this. So this is we have to pick an option here because we need an order to make the graphs. So that's the reason we need to show this. So how do we order it? If we come back to relative size on the next slide, we don't have to show this. This is an optional piece of information. And I think one of the questions for you today is this something that's meaningful? I do think that there could be mixed opinions on this. I mean, on one hand, it's really helpful to know who the large entities are in the state. If you're a really large payer and you have a bulk of a given market and you're doing really well, that's going to drag the state average up. if you're a large provider, you have, you know, a really significant portion of the attributed patients in the state, and you're not doing well, that's going to drag everything down. And so that's sort of relevant. Or I could see an argument that we actually, that's not relevant, that we have established a threshold and we've said you are large enough for public reporting. And so now once you're large enough for public reporting, we should treat you all equally. So I could argue this on both ways. Like, I think the question is that something that you all think is relevant to know? Johnny, can you go back one more? Can you go forward one slide? Forward. Yeah, this one. I mean, I always think more data is helpful, and then more data is overwhelming. So where's that line? Is knowing which organizations have the most enrollment and the most attributed patients meaningful to you in understanding cost growth? If you're thinking about, I want to know how my peer organizations are doing, is relative size a meaningful factor for you?
You know, I would say that that can be useful. Part of it is just the concern of how cluttered it gets, because we have lots and lots of entities. Pretty soon, you're not looking at the separate bubbles. You're actually looking at a whole, like a bunch of balloons for your birthday, and you just can't make any sense of it. I do agree and understand you need to show these. We don't need to go back to the other slide. I wouldn't do them kind of sliding off, because the whole question to me when I see a visualization graph is it trying to communicate something to me. Now, if you had the one on the thing we had the right where it went by descending size, if you're trying to get people a feeling to say, well, how many people are left or right, that actually could be useful, because very quickly you could look at it and say, oh, almost everybody's to the left, or everybody's to the right if you do descending. But then it makes it difficult if somebody wants to look up a particular entity when you got 20 or 30 of these. So I, once again, like you, Sarah, I can see wanting to do both. You know, that you could have reasons that people could want to say that it is important to see the really big ones in the state. Where are they sitting at? Partly because the smaller you are, the more volatility you're going to have year to year anyway.
Yeah, and the larger your confidence intervals will be in the reporting for sure. And I do think that, you know, there is some issue here of essentially the brand recognition, right? Greg, you're at Kaiser. Everyone knows who Kaiser is. And like, we don't need to say Kaiser is large because everybody knows that. Is that fair? Or is that just a really wonky, like, this is the land we all live in? For some of the provider organizations, they might not have the same visibility, especially some of the smaller, more independent practices. So I'd love to hear from you all, either on the call or over email, what you think about having that size. This is something that's come up in our individual conversations about the data. Folks want to say like, oh, you know, I'm a small FQHC or a medium FQHC. I don't necessarily want to be compared to a really large health system. We are not the same. I want to be compared to other FQHCs, and we're going to have that conversation next. But I think that's part of this relative size. Like, is this truly an apples to apples comparison across all payers and all providers if some are significantly larger than others?
Sarah, why did the provider and payer graphs even need to look the same?
Oh,
it's actually quite possible that I mean, they're related to each other, but they're not the same thing. And payers have a different level of control over cost than providers do, and providers have different levels of control over cost than payers do. So you cannot, they're really apples and bananas. And so as a possibility.
Eric, I love that so much. Let's pause for other reflections. Like, do the payer and provider graphs need to look the same? Maybe the payer graph has relative size and the provider graph does not. Thoughts?
Sarah, this is Mary Ann from Regents. To some extent, it's very hard without the actual data visualizing, but it feels a little like you could end up disaggregating the conversations in ways that are unintended if they don't have some similarities. I'm not saying they have to look identical, but it does feel as though there should be common threads throughout them and common kind of presentation. And I worry too much about having them look wildly different and one reflects size and one not, for example. But I do agree that the data will mean different things in the context of each, the payer and provider side.
Thanks, Mary Ann. I'm seeing mixed feedback in the chat as well. So some folks saying size matters for payers and providers. Some say no. I think no on the bubbles. I'm hearing a no on the bubbles, I think pretty consistently, like party balloons, bubbles are confusing. Possibly bubbles are off the table, but we might still want to explore what we can do in the bar charts.
Mhm.
Other thoughts? This is really great feedback, everyone. Again, just thank you for sharing and reacting. We don't know what the right answer is here, so appreciate working through this with you.
Sarah or Trang, a quick question, and Tracy again. The gray bar, the size of it represents what again? Maybe you said this earlier. I know it's the confidence level, but what is the smaller bar versus a larger bar?
So the length of those gray bars, it's the size of the confidence interval. So if you look at organization C, which has like a really big one, that means their per member per month, there was a lot of variation among those people attributed to them. And because of that variation, even though we got that point value, that orange dot, there's a lot of variance in the data. So that's why that's so big. So if you look at organization B, so organization C is, even with those large confidence intervals, it's still fully under the 3.4%. The organization above it, B, also has a pretty big confidence interval. And that's where the confidence intervals kind of come into play, because organization B was above the cost growth target. But
and in some ways it is the width of the confidence interval is a proxy for size. Larger organizations are going to have a more stable cost trend and will have smaller, narrower confidence intervals.
Yeah, for the most part. Yeah. But for organization B, if we were looking at this with like an accountability lens for organization B for this year, we would say, you know, we couldn't determine with confidence that you were actually over the target because there was so much variation. You crossed that line. So even though, you know, we kind of calculated your average per member growth as being over 3.4, we would call you, you know, indeterminate whether or not you met the target, and that would be the end of that.
Thank you.
Let's move to a couple of the next questions, because I think we want to get into a little bit more of this. Are the graphs or the information that we're trying to share different for payers and provider organizations? So next slide, please, Jody. This is specific to payers. So those of you who are payers, couple of options we have that we wanted to throw out at you. I think it was the Massachusetts report, they differentiated between the domestic payers and the national payers. That is also something relevant for Oregon. We have both in the reporting. We could do that in a couple of ways. We could have different symbols. We could use different colors. This quick mock-up is just showing different colors for the different domestic or national. So that's one question. What do you think about that? Is that helpful or not? Another question is adding a data point for the market average. So right now we are only showing each organization, each payer, but one thing that's come up in our conversations with you individually is, how am I doing relative to the market average? Not just how am I doing relative to the target, how am I doing relative to my peers, but how am I doing relative to all of the Medicaid payers or to all of the commercial payers? Would it be helpful to add an average to each graph? Thoughts about those?
This is Antoinette from Cambia Health.
Antoinette, we lost you if you were still talking. Your sound has disappeared. Okay, while we wait for Antoinette to come back, Jeremy's asking if these considerations would be on the same graph as the previous. I think yes. Other options, we could have two different graphs, one Medicaid graph for the domestic payers and one Medicaid graph for the national. That might start getting confusing, and then you're not looking at everything all together. I don't know that I would want them on separate graphs, so I think probably all the same graph. Suggestion in the chat, maybe an asterisk instead of color to differentiate. That's fair. Could also not do that. Could also assume that this is an informed audience and folks know that, for example, United is a national payer and not a domestic one. We don't have to call this out. This is optional information that we think might be a value add for context, but is not required. I'm seeing mixed. Yeah, Jeremy, we would not do color for size and to differentiate between payers. We would not try to cram both of those things on the same graph. I'm seeing mixed feedback about average. Could be a good idea, could be helpful context, or everyone's coming from a different place and the goal is really the benchmark, not the average. Anyone want to chime in verbally? Tracy says would rather see market average than size of payer. Great, thank you. Okay, payers, any other considerations that you would like to raise right now? And again, please submit feedback over email. This is a work in progress, but any other comments from payers before we move to some provider questions?
Well, this is Ada. I did put it in chat, but I still am curious about region because I think metro versus rural, you see very different trends, and it would be interesting to see that picture in Oregon.
Interesting. I feel like in some ways that might be easy for some organizations, but not all. Like all care, I'm going to pick on you, Ada, like all care is very easy to say where your region is, but I'm going to say United might have members all over the state. So how would we do that?
Yeah, I don't know if there's a both option where you have to normalize it, but yeah, I think about, for the CCOs, Medicaid, we're very region specific for the most part. And if you're in multiple regions, you kind of do it under different entities.
Yeah. I mean, I think for the CCOs, that's a really different story because we know exactly who the CCOs are and where your geographic coverage is. We could do the CCO map with the cost growth trends for the CCOs. That's an option. I think when you start talking about the Medicare and the commercial markets, it gets a lot more complicated. I think it's also complicated to do regional on the provider side. Some provider organizations are very regionally specific and others are statewide. And that would
and maybe that's the indication of, instead of going even to Oregon versus national, going down to the region level and saying this is a regional payer, a regional provider versus statewide versus national, because you may see trends at that level. And I don't know, not looking at the data, I'm just thinking, where could trends be? It might be an interesting indicator.
Let me propose to the team that we put together a really quick table of all the payers and provider organizations that would be in this report, and that we tag them if we think they would be regional or national or regional or statewide. I think this is something we'd want you all to weigh in on for your own organization and how you're being classified, because this is a pretty messy area. Yeah. And this might be where we want to do something just for the CCOs and not for everyone else.
Well, even at the MA level, because I know that our cost as it comes to contracting can be very skewed because of regional limitations. We don't have necessarily the network that some areas have or that a national plan may have. So it's just, it may be that the data's out there, it's not telling, and it's great, we move on. It's just kind of, as we start to look under the hood, is there something there? Because it might be informing.
Yeah, I think let's have our team poke at this a little bit, and we can come back to you in March, and potentially, if we think this is viable, we would want you all to sort of sign off on how you're being designated.
Cool.
Okay, let's go
Sarah,
to
before I was waiting for Antoinette to reconnect, but I think she's having some connectivity issues. So I will say, I think we don't find the Oregon versus national super useful, but we do think a data point for market average would be really useful.
Okay, Thanks, Marianne. Okay, let's go to the next slide and some questions for the provider organizations. So similar, we've had conversations with you again about wanting to be compared apples to apples. If you're a pediatric practice, you want to know how other pediatric practices are doing and that we shouldn't compare a large health system to a small group practice, for example. So we could, again, do different colors. We could do different symbols to differentiate between a couple different types of provider organizations. We could also do different graphs. I'm really open. I think we would absolutely need some more discussion here on what are the different types of provider organizations and how are each of the provider organizations being classified, and we'd come back to you with that, but putting that out there. And then same question here for the providers. What do you think about adding a data point for the market average?
I'll always have my opinion. I apologize, Sarah.
Nope, great, go for it, Eric.
I do think you're going to have to break up the providers into some sort of designated groups. Just the on-ground ability to be actionable with this data is different in an integrated health system than it is in a group practice or a subspecialty group. And so I think you're going to have to. Otherwise, you're just comparing, again, apples and bananas between each other. In terms of our market average, I think it depends on what you consider the market, whether it's valuable or not. So it's really, we'd have to look at the data to see.
Okay, so may or may not be helpful to have market average. Definitely a vote for separate graphs for different provider types. Deborah, in the chat, looks like you're also supporting calling out pediatric providers in their own sort of cluster. Are there any and I agree, we do have lots of providers organizations for reporting, especially in the Medicaid market, and this is where a lot of the FQHCs and the pediatric providers are pulled in, is just in the Medicaid market. So it could make sense to have essentially a series of graphs to show the different provider types. Are there any concerns about breaking that out?
At least in the pediatric market, we work together a lot, not just, through Deborah and her organization, but just, working together more as colleagues than as competitors. And what I would hate to see is any kind of data that comes out that creates a competitive atmosphere between the organizations where it's, that's just, I think, pediatric specific. I don't know any, I don't know about the other specialties or groups.
Yeah, I'm going to invite some feedback on this point specifically, because in some ways, this is one of those, I could argue this both ways, where competition here might not be a bad thing. If we see that one organization in a particular group of provider organizations is doing really well, like, what are they doing? We should want to identify that, and other organizations can maybe learn from that organization. So I don't know that that's necessarily a bad thing automatically.
Sarah, I would agree with you if the data had if the data was trended. So if one organization was doing well over time, you'd want to learn from that organization. If that organization, like every other organization potentially in that group, is just ping-ponging back and forth between meeting and not meeting, meeting and not meeting, then there's nothing helpful to learn from those organizations or from that competition. And that ping-ponging is the part that I think you hear me most worried about.
I think that's totally fair. And I think I'm already starting to get some ideas about data visualization for next year's report, where we will be able to start talking about multiple years and a longitudinal look. And I think the report, we might have this same version where we have the year-to-year snapshot, and then we might also be adding in a longitudinal trends section. And I'm looking forward to that. So I think, Eric, you're raising some really great points, but I think they might be more relevant for when we have one more year of data and can start trending. Okay, Tracy has a comment in the chat. Any intention to limit provider reporting to the largest providers? Dronny, let's go back to the slide with the org chart style. number of provider organizations. So there is a limitation, this one, yeah. So each provider organization and each payer organization has to meet a certain threshold. There's a threshold for data submission for the payers, and then there's a threshold for public reporting. So same thing on the provider side, there is a threshold there. So you all as payers are giving us data on many more organizations than have met this cut point. So that's already been applied, and that was based on implementation committee direction back in the day. It's a low bar. I mean, especially compared to some of those other states we talked about, where Rhode Island's reporting 4 payers and 10 providers, we're reporting 50 providers. That's a big difference, but there is a cut point here, and we do have a lot more data sort of below that. That's not part of this at all. Tracy, and I'm going to project that you're asking, maybe we limit it even further. Maybe it's not just the 12 Medicare. Maybe we only report the top 3 large Medicare. Is that where you're going?
No, I just know that other states limit it to top providers and wondered if.
Yeah, other states do have different cut points, and other states also have a much more consolidated market. There's only 11 accountable ACOs in Massachusetts for reporting, sort of full stop. So it's just a different program. Our statute has always been broad, and the program applies to all payers and providers in Oregon. So we've applied this cut point to make that manageable.
Thank you.
Okay, providers, other comments, questions, concerns about any of the visualization or grouping for the provider organization level data? Let's go to slide 26. We have one more question that we wanted to throw out there for you today. And this is coming back to that Massachusetts question. We have the data. We could show the cost growth for a provider organization's largest payers. So we'd be saying for provider organization number 1, your 2, 3, 5 largest payers are, and then here's what your cost growth looks like for each of those payers. What do you think? Is that something we should explore for this first report in the spring? Is this feeling like it's too much detail, too far in the weeds? Maybe we come back to this in a future year. Is this helpful? Is this confusing? Is this just going to be an overwhelming amount of data to publicly report? What do you think?
My question is, what's the point of reporting that to the public? If, I mean, again, the data needs to be actionable. You want the public, you want legislators, you want providers, you want payers to take action on this. This doesn't seem actionable if you put that information out there.
I might push back a little bit on whether or not this is actionable. I think this has the potential to show that a particular payer is maybe that there is variation at the payer level, and that's showing up in a variety of different ways. This provides additional granularity than what would just be in the top line payer level reporting. Whether or not that I don't know what action that translates into. I don't know if that means that, as a provider organization, you might say, oh, clearly all of my cost growth is being driven by this payer. This is where I need to focus my efforts, is on this payer's patients, or in working with this payer on other various initiatives. I think there could be actions. I really hesitate to say that this is going to be prescriptive in what those actions should be. Payers, this would be more data than you might be anticipating reporting. How do you feel about this? Ooh, okay. This is a tricky question. I'm going to expect a bunch of emails from you on this.
Sorry, I'm going to be honest, I totally missed it because I had a ticket come in.
Fair enough. Okay. I think we have some other agenda items, so I think I'm going to stop here. I totally didn't mean to take over facilitation. I'm sorry, Trang. I'm going to turn it back to you to wrap us up on this.
No, you're fine. That was great. Yeah, so please, these slides are uploaded. Our email inbox is always open. Next slide, Gerandi. Speaking of feedback, yes, you are correct, March 15th. So thank you so much. We got so much feedback from folks in the chat verbally. This is really great and exactly what we're looking for. So if you have other feedback, if you want to take this back to your teams, maybe folks that weren't able to attend the meeting today, please do so and send us your thoughts via email and try to get it in by March 15th. All right, yeah, and it sounds like we will be bringing back additional mock-ups and questions for our group at next month's meetings, which we definitely, yes, can do that, have time for. So with that, thank you so much, and let's try to wrap up some of the remaining agenda items. I think I'm handing it off to Sam. Next slide.
Yeah, thanks, Trang. These should be pretty quick updates. It's been a while since we met in the tag, so this is probably stuff that remnants from what we would have been covering late in 2022. Just playing a little catch up here. Let's go to the next slide, please, Johnny. So our provider organization list of entities that we're going to be reporting stayed pretty similar, which we love to see the consistency. We had one new provider organization, Sanford. I think we heard from them earlier today. Thanks for joining. And one organization dropped off. So that consistency, that may not be the case year over year that we see this level of consistency, but especially when we, in a couple of years, when redetermination hits and some of our Medicaid provider organizations start losing some of those members, we might see some more provider organizations drop off. But that's just a quick update on which orgs are different from 2021. Let's go to the next slide as well. So the list is publicly available. So last year's list is still up on our website. This year's list is up as well with some more information. If you end up going to that link, there's some good stuff for the provider orgs. One thing we are doing different, I think Trang is going to cover this maybe in a little more detail. We're not meeting with every single provider organization mandatory like we did last year when we were wanting to make contact with everyone. This is more, there are going to be some more optional meetings, and we can talk about what data we have available going forward. But a lot of these, the ones, especially the ones you see on the list right here, are going to be ones that we're going to meet with every year because they're doing a lot of seeing so many more members than some of the smaller organizations who are maybe borderline included in our group. So that was just essentially an update on who's on the list and letting you know that we've got that updated list posted. Are there any questions about, you know, any changes that we made from last year, or, you know, why you're included on this list or why you're not, maybe? We're happy to take your questions always via email too, if you want to get to us a little bit later. Not seeing anything. I guess there's some chats I didn't see, but those aren't relevant. So let's go to the next slide, and we're just gonna touch on maybe a little preview for this next data cycle. I know we just got done with this last one, but we're already thinking about changes for the next year. Let's go to the next slide. Data submissions are you know, due by payers in September 1st of this year, so we're not quite ready to start accepting submissions, but we need, if we're going to be making changes, we need to start thinking of them now. We don't have any, thankfully, and I think you'll all be happy to hear this, any large significant changes to the way we're collecting our data. We're still doing demographic scores, we're still doing the same attribution you know, levels that we've done in the past. So hopefully that consistency, that year over year consistency, will make your life a little easier, it'll make our life a little easier, and it'll make our reporting, that consistency year over year, really make a lot of sense. And so if we can get our visualizations down like we're trying to, then that consistency is just gonna make it easier for everybody to input this data, you know, in the summaries that we have. So again, if you go to the website that was kind of linked on the last time, the Cost Growth Target website, it's a great resource for you know, any of the templates that we have used in the past or what we're thinking about changing to in the future. We have a frequently asked questions document out there that you know, you can check before you email us, or you can just email us and we'll probably point you in that direction if it's asked on the FAQ already. Again, you know, we're probably going to be talking about this more in the March meeting. So if you want anything to be you know, included in that March tag, please get it to us as soon as you can. March 15th is our general deadline for questions, any changes that you'd really like to see. I know we talked about some of them that you know, in our payer meetings throughout the last year, and there was nothing huge requested, no big promises that we made either. There's just maybe some minor tweaks here and there. So if there's something that's very important to you, please hit us up to make sure it's included. Do you have any questions? Let me just pause for a second. Okay. Let us know if that changes. The email on the screen is very useful. Jot it down. With that in mind, we're going to go to the next slide, and Trang is going to cover some program updates. I think this is going to be relevant for payers and providers, so hopefully everybody stayed on the line.
Yes, and these will be pretty brief. We can go to the next slide. So these numbers are a little bit different, but as of the 15th of February, we've had 14 provider organization meetings. Well, meetings scheduled, 8 completed. That number is actually increased. We've been meeting with folks all through January and February, and it looks like we're going to meet with some early March, but then that will be it. Just another reminder, all 51 provider organizations that met that size cutoff, we sent data summaries for everybody, met with all of our big organizations in the state, and for everybody else, we made ourselves available for meetings to discuss their data summary and or the program in general. I think that's all we wanted to share with this. Let's go to the next slide. A quick update on those 3 introduced bills in the House that may affect the cost growth target program. They're all still alive. Well, before I get into it, just know this presentation is for information purposes only. OHA does not have an official position on any of these bills. We are not asking our TAG attendees to take a position on any of these bills. This is just for informational purposes only. So there are 3 bills, they're listed there. 2 of them had public hearings last night, and the recordings for those, they're on the Oregon Legislative Information Service system. They're on the OLIS webpage, usually the day or 2 after, and we have a link on the next page if you'd like to see it. So that's where they all are. They're all still alive. It's still early, you know, in legislative session.
And I think we have agreed to continue to notify the Cost Growth Target Advisory Committee and the TAG if any of these bills are up for a public hearing or if they move and as session continues. So we'll keep you posted if there's another opportunity or anything scheduled on these. But again, just wanting to be really transparent with everybody about what's happening legislatively.
Oh, we have a question in the chat, Sarah. If any of these bills pass, when would they take effect?
2085, which changes the program to focus not on total healthcare expenditures, but on premium cost growth. I think that bill takes effect immediately, but then we'd have to figure out what that means for our data reporting cycle. And when and where things change. If we're sort of mid-change, I think right now it does not say when it would change the data, and we'd have to sort of figure out the operational details for that. I suspect that that could have some immediate implications for the 2023 data collection cycle if that passes as scheduled, but I'd have to double check. For 2742, same thing. I think that also takes effect immediately. We'd have to figure out operationally if that affects the 2024 data cycle, the 2023 data collection cycle, or the 2024 data collection cycle. Sorry, Julianne, that was vague, but hopefully that helps a little bit.
Yeah, that helps. Just trying to think. September's coming sooner than we know it, so.
Yeah, let us confirm. I can look up the effective dates and we can send a quick email out to the TAG as follow-up on if we think this would be a change to the 23 data collection or the 24 data collection cycle.
Thanks.
Any other questions? Let's go to the next slide. This is just a link to our state legislative information website. You could look up bills, public hearings, work sessions. As I mentioned, we had 2 public hearings last night. So far, I don't think any work sessions planned on any of the 3 yet. But yes, please check that out. Let's go to the next slide. I think this is our wrap up. Yes, it is. So congratulations, you all made it to the end. Please continue to give feedback to our email ahead of our March meeting. Our March meeting is at the end of March on the 22nd. We're going to review changes to the 2023 data submission material. Again, nothing big or substantial. There are some clarifications that we want to add in, and I think one of the changes is we're going to edit that statistical methodology document to make it a little more clear how those confidence intervals are calculated for provider organizations. So it's things like that, nothing big. What's not on here, but we did talk about it today, is that we are going to bring some more mock-ups and maybe topics to get your opinion on regarding what entity level reporting looks like. So that will also be on the March TAG agenda. Anything else from OHA team, Sarah, before we sign off? Okay. All right. Well, thank you so much for spending 1.5 hours of your Wednesday with us. We really appreciate it. The conversation's been really great. So thank you. All right. Bye, everybody.
Thanks, everyone.